You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 5th, 2024. Our topic today is jobs, contracts, and more. This is presented by Dr. Aarti Pandya, an assistant professor of pediatrics in the Division of Allergy, Immunology, Pulmonary, and Sleep Medicine at Children's Mercy Hospital.
Thank you, Dr. Miller. All right, so today we are going to be talking about jobs, contracts, and more. My name, again, is Aarti Pandya, and I'm here at Children's Mercy as well as UMKC. So, disclosure, I'm not an expert on this topic. However, historically, I've given this talk to our fellows as well as on the COLA series now, and I've received feedback numerous times that it has been an invaluable kind of introduction into important concepts that are needed to know and kind of explore while you all are looking for jobs, and the right questions to kind of ask on your interviews, and to kind of make sure that you are set up for success in this process going forward. So that is why we are doing this talk today. Before I kind of get into the details of it, two other things here. One question that Dr. Miller kind of mentioned here is, when is the time I should be looking for jobs? I'm at the beginning of my second year, or I'm at the beginning of my first year. When should I be thinking about this? And the answer to that is that, really, you can look at any time. This is something that we think kind of at any point during our fellowship in terms of like long-term planning. However, in terms of seriously looking for jobs, most fellows kind of start, or I should say not most fellows, but the earliest time that fellows do start is generally at the end of their first year, beginning of their second year. As Dr. Miller mentioned, that process does take quite a long time. And so that's kind of one thing to think about. Also, this talk is for you guys as fellows, or for you all as fellows. So please feel free to kind of ask questions throughout this, and I will try to not belabor my points too much, so that at the end you have plenty of opportunity to ask questions. So first thing that comes to mind is, okay, well, I'm approaching the end of my training, I'm approaching the end of a monumental, time of my life, and now I need to think about the next step. But I don't even know where to start in terms of knowing what type of setting I should be working in, and all of those things. So what's a good starting point for me? And the answer to the question is, it's going to be dependent specifically on your needs. And so a lot of these questions that I've outlined here are reasonable questions to ask yourself, because knowing the best job for you is knowing what you need for yourself. Ultimately, those two things go hand in hand. So first thing here, how do you wish to practice medicine? What kind of setting, if any, is priority for you? What kind of compensation would you prefer? What level of compensation do you prefer? How do you view working in a managed care environment? And then these are other like life-related questions that we ask ourselves. What type of setting do you prefer to both practice and live? And can those be different depending on the area that you are looking into a job, for instance? And then, what's your family situation like? Do you have kids? And if you do, what kind of school system is going to be important to you? What is the most important consideration for your professional practice? And the second most important consideration. These are all brainstorming questions that we ask ourselves to approach this topic, so that we get an idea of what works best for ourselves. Additional questions that we take into consideration include, what type of patient mix do you prefer? How many hours per week do you wish to work, excluding call and including call? How many days of call each month are you willing to take? And how important are job opportunities for your spouse, significant other? So all of those things are things that we think about, and these are all potential options or different possibilities of things that you may be approached with. One other thing is, if you're working in a private setting, is there an affiliation with a major hospital, and do you have any inpatient responsibilities with that? But the bottom line here is answering these questions can give you a sense of what your priorities are, so you can make the best decision for yourself going forward with your job. In terms of the preparation process, what do you need to have ready? Let's say if you start looking for jobs right now and you're going to submit materials about yourself to that potential practice. These are some things that are important to know about. So, and I kind of mentioned here, it's always good to start early. Everyone is different. Not everyone starts this early at the beginning of the second year or end of your first year. Some people wait a little bit longer. But it's just good to at least kind of think about this. Also, if you're in a research-heavy institution, do you plan to take another year of fellowship while you kind of figure this out? And then if you're gearing towards the end of that year, that could also be taken into consideration. But these are a couple of things that I would recommend having on hand. So first is making sure your CV is updated and ready to submit at any time for a potential practice. Second thing is having a cover letter ready. And we're going to talk a little bit further about both of these in terms of, how to have these ready, essentially. Letters of recommendation. Not every job that you apply for will require or ask for letters of recommendation. However, there are, certainly when I was applying for jobs, I had one or two practices that did ask for letters of recommendation, especially if you're looking in the academic setting. This is something that is common for academics. And in terms of getting a strong letter, that's very important here. You don't want a letter that is anything less than showing you in a glowing, shining light, especially if it's a job that you're really interested in. So one way to phrase that question to your letter writers is, are you willing to write me a strong letter of recommendation in support of my future job prospect? Wording the question that way will get you a good idea of whether a strong letter can be given by that potential letter writer or not. And ultimately, if they say no, then it's not something, it's better that you know that now rather than getting a weak letter of recommendation and then not getting the job that you want. So these are 3 documents that I would kind of keep ready, essentially, when you're kind of starting out in this process. And then in terms of timing and preferences, that's what we talked about. How do I find potential opportunities? So word of mouth is a common way that we know that some opportunities are available. And so depending on the structure at your program, if you talk to your various attendings or leadership at your program, they may know of different practices that are looking to hire. Both the college and quad have career centers on their website, so exploring those, especially if you're looking at particular areas. Networking events, so the Quad AI has a virtual job fair as well as an in-person one, and the college has an in-person job kind of opportunity as well for you to job fair, I should say, to look into. So checking the times during the conferences. Recruiters are a potential way to also look for jobs, although, A&I is a little bit more limited than something like a hospitalist job. So just be careful if you're using a recruiter in terms of that, in terms of, making your resources worthwhile, I should say. Emailing and calling desired places directly. Sometimes private practices, etc., are not advertising it, even if they are looking to hire essentially in their practice. And then especially if you're interested in academics, the program directors and associate program directors of fellowship programs have a running list that they receive monthly or every other month of academic job opportunities across the country. So I remember that was something I was interested in, and so my program director would always make sure to forward that over to me when I was in my second year. So these are different ways that we could potentially look for job opportunities. All right, this next part. how to make yourself marketable. This is not an all-encompassing list. This is just some things to kind of think about in terms of making yourself marketable when you are looking for a job. And in terms of some of these different points here, these will kind of fluctuate with time depending on how things are changing with things like AI, et cetera, going forward. If you're looking into, and the timing of when to make yourself marketable, so this is what's applicable to both our first years and second years. So, and I know that that's difficult to, especially right now, think about because you're right at the beginning. Many of the first years are even taking their primary boards like internal medicine or peds right now. But once you kind of get to a point where that's complete, then you start thinking about not only do you want, of course, you want to be the best fellow and shine in the best way in your fellowship, but how is your fellowship going to set you up for the best job in the future? What opportunities should you take hold of early on in your fellowship so that you are, kind of an attractive candidate going forward for whatever job you're interested in? So if you're looking into academics, the one thing that they are looking for is what do you have to quote unquote offer the university? Is it specific research training? Is it administrative experience, leadership, patients encountered during your training, i.e. do you have more pediatric versus adult experience? Do you have a specific immunology subset of experience that could be applicable, going forward to the position that you're looking at? So it's important throughout your fellowship that not only are we doing the training, but we are looking for opportunities that bring us professional advancement, whether that be research, joining committees, any of those things are things to kind of think about. If you have a particular niche with technology, being familiar with different hospital information systems or computer-aided instruction, image analysis, etc., telemedicine, these are also important skill sets that can set us up for a unique position to be in when you're applying for jobs. How about broad work experience? So if you were in a fellowship training program, did you rotate at private practices where you were seeing volumes up to what a normal private practice sees? That could potentially give you a leg up. If you are familiar with medical Spanish and if you're applying to areas that require medical Spanish literacy, or I shouldn't say require, but it's in your benefit to have medical Spanish literacy, of course, that's an additional skill set that you could have. And then also understanding the job hunting process itself and how you present yourself, because the more knowledgeable you are about this, employers will pick up on this, knowing the language that's around the job process. All of that is going to serve you in your favor in terms of looking for jobs. So what drives the employer's search, the market trends in the area, how an employment would offer potentially good match and mutual professional expectations, and then clearly communicate why the position you're interviewing for is a good long-term career move for you. And then lastly, of course, being flexible in your expectations, not in the sense of compromising everything that you want necessarily for the job that you're looking at, but knowing that one job cannot necessarily have everything. So knowing that kind of going into the process. So in terms of kind of some of this terminology of what I was talking about earlier, what's the difference between a resume and a CV? So a difference is that a resume is typically very short, has medical education with few accomplishments. A CV is typically, excuse me, much lengthier. It lists all your academic and professional accomplishments in detail. However, I would not recommend exceeding more than 4 pages for your CV, so it should be precise. For those of you who are interested in academic practices, in terms of how to structure a CV, the AAMC website actually has the exact format that I utilized for my CV when I was applying for jobs, and that I highly recommend to our fellows when they're creating their CV for job applications. So I didn't write that down here, but again, just so you know, AAMC for a formal CV. Okay, now cover letter. This is basically a letter that you're writing to your potential employer about what you find interesting in the position and then what you can offer. And it also emphasizes your best qualities and all of those things. So how do you structure a cover letter, and how do you approach this essentially? So I will tell you in my personal experience what I did, but every person is a little bit different. So just know that you should cater this towards what your needs are. So for cover letters, in terms of what academic practices as well, compared to what private practices are looking for, are a little bit different. In a cover letter for academic practices, they're really wanting to highlight, again, in terms of academics, what you have done in your fellowship that make you stand out. Whereas in a private practice, they're looking for things more like, what type of patient demographics have you seen, and what kind of clinics you've rotated in, that type of thing. So that's one difference to keep in mind. The second is, should your cover letter be catered specifically towards the practice that you're interested in, or should it be just a general cover letter that you write? And basically, in my personal experience and with talking with fellows across the country, both have been done. So if it's a particular program or particular position that you're really, really interested in, there's nothing wrong with modifying a general cover letter you have written to specifics about that program or that position. Calling out the position name directly, or like the institution name directly in your cover letter, highlighting what you like about that particular institution or practice, etc. So both ways are very reasonable in terms of doing a cover letter. The one piece of advice I have is keep it to 1 page maximum. After about a page, your person who's reading the cover letter is going to not have their attention fully there. You want to be concise in what you're trying to say and efficient, but also emphasizing what's important. So try and limit that to 1 page if possible. So letter of recommendations, how many should you get? I would say for most places, 1 to 2 is sufficient. 2 if you're wanting to be extra prepared. When you are asking, we kind of talked about, how to ask for a good letter of recommendation. And then in terms of kind of professional courtesy, you want to give your letter writers at least 3-week notice, and at the same time, make sure that they are aware of your deadline. And then once they have written the letter for you, making sure you follow up with some type of personal thank you, because this is a little bit different than writing a letter just for, your fellowship or your residency. This is a bit more than that. This is writing an official letter of recommendation for a job that you're potentially very interested in. And so that brings the next question, well, who do I ask, in terms of my fellowship? And again, this is something that more so you think about in your second year as compared to your first year, but who wrote you the best evaluations? Did someone, spontaneously ask about writing a letter for you? And then I kind of mentioned how you should ask the letter writer for the practice that you're thinking about, so you ensure that you're getting a strong letter of recommendation. Before you interview, and especially with traveling for interviews and things like that, it's useful to set up a phone interview if the practice allows you to do so. This is to gain a basic understanding of what kind of position you're interviewing for, and it also helps to know if that is something you're looking for or not, if it's worth the travel or not. Because the last thing you want to do is think that you're interviewing for one position, but you're actually interviewing for something different. You traveled all the way for the interview, and then it's ultimately kind of a wash. So having that phone conversation ahead of time can be very helpful. You can look over the website or the practice or the university of the practice or the university. However, nothing beats getting on the phone with your whoever is going to hire you and getting that information directly. So again, we kind of talked about a lot of deciding factors here. None of that has changed here with this slide, but some additional things just for you to brainstorm is being around family important or not? Do you want to go back to your hometown versus have a new experience, location, academics, financial goals, and then type of work environment? So in terms of practices, there's 4 major ones that I've highlighted here. The first is, of course, academic practices or university-based practices. I should make a note here that academic practices are not limited. So of course, there are practices where you work for a university and, you have a hospital affiliated with that. There are also hybrid models too, where it could be a private practice that you work for, but you do have a university affiliation. So know those details when you're asking questions about the position. These are kind of more rare to find these days, but health system model based practices. So you're employed by a health system itself. One example here is HCA Midwest in the greater Kansas City area. And the reason people think about health system models is because your benefits are through the health system. However, your practice could potentially be set up the way you want it to, or it could be dictated based on what the health system needs. But in terms of standardizing things like your benefits and salary, etc., potentially your starting salary versus like your continued salary, those things could be more kind of, like I said, standardized with a health system compared to a private practice model. Again, just knowing if that's important to you or not. And then, of course, we have private practices. And again, you could have a hospital employment here. You could be physician-owned. You could have a multi-specialty group. So I have a couple of friends who have worked for practices that are like allergy plus ENT together. And then, of course, you have physician-owned practices. And then you have private equity owned practices. Very important to know who owns the practice and who ultimately is coming up with the rules and regulations that you need to follow in terms of the actual practice. And then there's locum tenens, where you're working for a locums company and essentially you're being assigned where to go based on where locums needs you to go. And oftentimes you may have a say in that if you want to go to rural Arkansas versus stay in a major city area. Other things in locums to know is what are the times that you are employed, like what are the times that you're working, what does your salary look like? All of those things are things to know about with locum tenens as well. How do you make money from a practice? There's 4 major ways that you make money from a practice. The first, foremost and most important is going to be your salary. So this is essentially your take-home pay at the end of the day, and it's going to vary again based on academics, private. It's also going to vary based on private equity, etc. Is it a fixed model or is it a production model? If it is a fixed model, how long is it a fixed model? And do you have the potential to convert to a production model in the future? So why am I saying these terms here? Because generally in a production model, you have the ability to make more compared to a fixed model. However, when you're first being hired into a practice, they are essentially investing in you because you haven't built your patient base necessarily yet, etc. And so they're kind of investing in you as an employer, but at the same time, when you've worked in a practice long enough, if you are converted to a production model and if there's opportunities for bonuses, that's important for you to know. Signing bonus is another way you can make money. However, this is a one-time thing where you get a bonus right at the beginning, and then that's it. Relocation allowance, especially if you're moving, and then loan repayment, hot topic, of course, these days. So all 4 of these can be different ways that you essentially, quote unquote, make money with the practice. And it can be important, right? For instance, if you're in a PSLF program, like I have been in, you are kind of restricted to non-for-profit practices for a certain amount of time prior to being able to work for a private practice model. However, if the private practice is ultimately offering to write out or completely pay off your loans, I mean, that's a huge potential expense. The average amount of loans a physician has these days starts between $400,000. So that's a big chunk of change that could potentially be repaid for you. And then these are all additional expenses that you just need to think about. Who's paying for your licensure, DEA? Are your boards being reimbursed? Do you get some type of stipend? Are you RVU based versus salary based? And then is there an increase based on your performance versus strictly being non-RVU based? And then if you are RVU based, what model are they following? Are they following the AAMC model or the MGMA based model? The MGMA model is going to reimburse higher than the AAMC model. So again, just depending on what your priorities are, that could be important to know. Does your practice own an infusion center, especially if it's private practice? And if so, do you get money from the infusion center? Or is that limited just to the partners of the practice? It never hurts to ask. I have a friend who was going through this process who did apply to a place that had an infusion center, and the infusion center cut was going to the owners of the practice. However, he negotiated in his contract without being a partner to get a small take of the infusion center. And small take is a relative term here, because infusion centers make a lot of practice, but essentially that's another way to make more salary at the end of the day. In a private, and I kind of emphasize this point, that you're building your patient base, you're kind of an investment initially for the practice, but that's okay. That doesn't mean you can't ask for more. And then lastly, when are you eligible for a raise and what parameters are assessed for this raise or bonus? If you are in academics, if you get lucky, and if you're, of course, interested in the academic pursuit, whatever it be, administrative, research, clinical, whatever it be, many times now, the academic practices are offering bonuses based on your academic contributions to the university. And then, of course, in a private practice model, it could be based on your RVUs. So all of those things are important to know. How do you determine your market value? Research MGMA, AAMC, and then just the comps and stats in your particular area. That'll be very important information to be armed with going into an interview, because you'll get an idea of, are they offering you below market value, or are they offering fair market value? Or if it's a job you're particularly interested in, are they offering you higher than market value? If they are, make sure you know why, make sure you know how that money is coming into the practice, and if that's a sustainable thing for that practice or not. But just, again, arm yourself with that information, especially if you're restricted based on the location you want to end up in. So what is the overhead to revenue ratio? This is additional terminology we want to know about with regards to private practices, especially physician-owned practices. Overhead is essentially what the practice is paying for in order to sustain the practice. The office space, the light bill, the supplies that you utilize, all of those things are things that contribute to the overhead. So what is the percentage of overhead to revenue ratio? The average percentage is going to be about 40 to 60%. So you can ask this question, but if it's higher than 60%, where are those expenses coming from / going to? And then what is the payer mix? What are the type of insurances? Are there any excluded? And if so, why? Medicaid, Medicare. Medicare, there could be some opportunities to earn additional either RVUs or compensation, just depending on the setting that you're in. So keep that in mind. HMOs or self-pay. If they are accepting self-pay, what is the long-term kind of plan that practice has to make sure that practice doesn't lose money at the end of the day by seeing those patients? Not that I don't say that in a way that we should ever compromise patient care because of this. Never, never, never. But it is important for you to know in terms of your personal decisions about, going forward to committing to a practice, essentially. And what type of benefits should you be looking for? These are the many ones that are available here: medical, dental, vision, retirement package. After how many years of working at the practice are you eligible? And do they go with a standard company for your retirement package? Do they go with a standard plan, 401, 403? And what is the matching? Meaning, if you contribute 6%, do they match 3%? If you contribute 20%, do they match 18%? I mean, these are variable numbers that I'm telling you here, but it's important to know that. Tail coverage, very, very important. So this is referring to malpractice insurance, which I have an additional slide on. Clarify for private practices. Most university practices do provide this. However, even in terms of a university practice, how long do they provide it for? What radius do they provide it for? We'll get into that in a little bit. Disability, short and long term. I want to make a point here to emphasize to every single trainee who's on this call here. If you are the primary earner in your household, and if some disability hits you, essentially, then it could be prudent to have short-term disability to ensure you have a good amount of money coming into the future. I have an additional slide on this, I believe, but the reason I bring this up in the context of saying trainees is because rates of short-term disability insurance are much cheaper for a trainee. If you have inherited this from your residency already, please think 3 times before discontinuing this plan, because it is very hard to get grandfathered into a quote-unquote cheaper or like a low-paying plan, and that price skyrockets once you complete your medical training. And then make sure the terminology says own occupation short-term disability insurance. CME dictation up to date. Up to date is expensive. Very expensive. We are lucky to get it in training if we have it, but if you don't, it could be a nice service or nice thing to have. Interpreter services, memberships, and then payments for specialty boards. So partnership is relevant for private practices. Not all practices offer partnered positions, but it's important to know if that's a priority for you going into the interview. Is it a partial partnership? Is it a full partnership? How many years do you have to work in that practice, or how many RVUs do you have to make within a certain amount of years to be eligible to be partner? Is there a buy-in? Is there a certain amount of money you have to pay into the practice to buy into partnership? And then what are the implications of buying out when your partners either leave or retire? Specifically in allergy practices, if a partner is retiring, one of the things to think about is the allergy shot production. Is that going to the partner who's retiring? Or does that all come to you? This is a real life scenario that's come up that I know about with a couple of colleagues I've talked to. So it's something to keep in mind. Allergy shot, or allergen immunotherapy is a huge source of revenue for any private practice. All right, private equity. So I'm not an expert on private equity at all, but I do think it's worth at least talking about for a little bit. So private equity essentially refers to firms that have acquired private practices. There's a couple of major ones that are across the country. Allergy Partners, for instance, is one of them. And previously, most practices were privately owned by a few individuals, largely physicians. So the firms are essentially where the practices have been sold to the firm, and your practice expectation comes from the firm. So how many patients you see per week, how many clinics that you need to do, and your salary is also dictated based off of this too. Additionally, your bonuses, even whether or not there is a bonus or not, could be dictated from the private equity firm. The advantage is the private equity firm really should be taking care of your marketing needs, but that's something to ask about, is how are they taking care of the marketing needs? The advantage here is that you can build a patient practice very quickly right off the bat when you're first joining, without having to market yourself in the beginning. So very important to ask who owns the practice and the expectations. University appointments, these are terms for us to know. There are 4 major university appointments you can have. Clinical instructor, which denotes the lowest of the 4 rankings, and it often denotes a lower payer amount or a more, I don't want to say difficult, but in terms of how your voice is taken to the university or to your group could be different. So clinical instructor is the lowest. Then you have clinical assistant professor, associate, and clinical professor. The majority of universities hire you as an assistant professor. However, there are universities across the country that hire you as a clinical instructor. The thing to be aware of is that once you're hired as a clinical instructor, you have to wait at least 5 years prior to promotion to an assistant professor, where most people start off their university practice. And then there's an additional 5 years before associate and additional 5 years before professorate. And all of these are difficult to get, essentially, when you're applying for promotion. There's an entire promotion process that goes through the universities. And so you want to make sure that it's not more difficult to get to where you are ultimately wanting to end up. And then there also could be tracks, quote unquote tracks, that the university is asking you to designate yourself as. Are you purely clinical? If you are in a university practice, this could mean that you're seeing up to or you're doing up to 8 half days of clinic per week, or even more. Are you interested in education? If so, what kind of allotted time do you have in the beginning? And then what kind of time can you gain based on whatever positions you ultimately end up with? Is there a research track? Are you interested in research? Is there anything you bring research-wise, like a grant or something like that, to your institution? And then clarify for each individual track what percentage of time is needed and what percentage of time you're getting, essentially. CME, these are essentially days that you are given for continuing medical education, for activities. It could be for conferences, it could be for applying different credits so that you maintain your medical licenses, your ABAI, etc. So make sure you ask about allotted days and funds for CME. Okay, malpractice insurance. So malpractice insurance is essentially a specialized type of professional liability insurance that covers the physician in terms of liability arising from disputed services that result in injury, death, or dissatisfaction from a patient's behalf. And this is usually available through traditional insurance carriers or from a medical risk retention group. And there's 2 basic types of malpractice insurance: claims made or occurrence. Claims made only provides coverage and policy, but in effect, both when the incident took place and when a lawsuit is filed. So some claims made policies are written to provide a period of coverage referred to as tail that extends beyond the time after your policy has ended or after you've left the practice. So the cost of this covers your previous practice, adequate protection for their group assets, and essentially this is something depending on the practice, it may or may not be able to be negotiated, but what length of time does your tail coverage extend for would be important to know. And if you retire from the practice, is it essentially something that carries with you, for the rest of your life? That's important to know. And then occurrence types of malpractice is a different one, essentially that covers any claim for an event that took place during the period of coverage alone, and typically this does not offer tail coverage. So ask about cost of malpractice insurance, whether it provides malpractice, whether you're paying for it directly, and then the tail coverage. Restrictive covenant is also or is often referred to as non-compete, and it's an agreement between the employer and the employee's ability to compete after leaving the previous employer. So I will make a disclaimer right here at the bottom. There's, as many of you may have seen or heard, there is currently legislation that's passed that is trying to make these non-enforceable. However, just know that the applicability to physicians is something that's still being evaluated and has not been fully outlined yet. And so just keep that in mind. Additionally, important things to consider include the employment can proceed without violation of a provision, whether the provision is enforceable or not. If it's a very restrictive covenant, it may not be looked at as enforceable, so keep that in mind. And then the likelihood that the former employer will take action if there is a breach, so keep that in mind as well. And then the contract can list, in terms of your restrictive covenant, the distance from the clinic, the time period, and types of patients. So if you are looking over your contract with an attorney, just make sure to kind of discuss that in terms of what that means for you. Your schedule, is it flexible, fixed? Do you have admin time? Do you work weekends? Do you have inpatient responsibilities? Do you have call responsibilities? And how is your vacation structured? Disclaimer, not all practices have vacation that's structured. Some of them may just say you can take whatever and however much you want as long as you're maintaining your RVUs. But what does that mean practically? Maybe that's something to discuss with the people who do work in your practice, because that can be as little as 2 weeks when you're initially starting a practice, or it could be more. And what are the implications if you don't meet your RVUs 1 month, or over 4 months, or over 6 months? All of those things kind of take into consideration. Okay, labs and imaging. So is there an in-house lab? Is there an in-house imaging? If there is, who reads the x-rays? Because sometimes there are practices that there's not a radiologist reading it. If you order a CT sinus, you're legally responsible for the read that goes associated with the CT sinus or with the chest x-ray. And the reason that is because there's a radiology fee if you do want a radiologist to read that. So practices can often forego that, but then you take the liability of whatever gets signed for that image. And do you have the expertise to be able to do that? Just make sure you kind of know that and clarify this with your employer. Okay, allergy shots and infusions. So firstly, starting with skin testing. Depending on the practice, who is doing the skin testing may vary. It could be an LPN, it could be an RN, and then, or it could be where the RN or LPN places it, but then you ultimately have to read it as the physician. So keep that in mind. For allergy shots, are the shots all pre-made mixes, or are they customized based on skin testing? I know we talked about this a little bit during our orientation series, but so now looking at the practicality of how this plays out, some practices only do pre-made mixes, and it's because it saves the practice money, essentially. And so keep that in mind in terms of if you're comfortable with doing that for your practice. Are patients placed on shots with negative skin testing? That's something else to keep in mind. And then with mixing, following the USP 797 guidelines, who's doing it? Is it physician, mid-levels, nurses, or are you outsourcing it to the actual allergy company to do the mixing? And then who is administering the shots? Is the practice allowing home shots, slit? And if it's slit, is it FDA approved slit, or is it custom made slit? And are you comfortable doing custom made slit or not? So all of those things you want to think about. And then in terms of shot clinics, what are the shot hours, the schedule for your individual coverage? What is the schedule for buildup and maintenance? And for immunoglobulin, does the practice limit to only IV or sub-Q? Do they do infusions in-house? Are they partnered with an infusion center? If they do it in-house, do you get percentage of the profit? And clarify if you have privileges at the local infusion center. If you don't, you often have to outsource ordering of the immunoglobulin to whoever does, like a primary care or a hospitalist or something like that. And then who assists with the orders and labs follow-up? Importantly, biologics. This is a prominent part of our job. And do you have dedicated support staff for helping you fill out the paperwork? Majority of biologics require a PA, and even when PAs are completed, a decent amount require an appeal letter. So what is the process or support that you have? Are practices avoiding biologic therapy because they don't have the dedicated support staff to help you with paperwork? All things to know about. What's your staff makeup? Are there additional allergists? Are there other subspecialists there? Do you have trainees that are rotating? What is the nurse to physician ratio? What is the adult to peds ratio? Office manager? Who manages the billing? Is there an MA? Who does check-in? Does clinic staff put in orders for you? Who does prior auths? Has there been any anticipated staff turnover, and if so, why? And who sees same-day patients? That's going to be different based on every practice. HR or some form of HR is generally going to cover the billing. So this is access to measure the productivity or performance. And then if you're not in a non-RVU based practice, how do they calculate productivity? Who does the billing? How often is it reviewed? Is it reviewed in a staff meeting setting? Do you have to meet with your director or boss, etc.? And then is there an EMR system like Epic, Cerner, etc.? Is there a dictation system, Scribe? Is this a practice or a paper-based practice? So for those of us who are in Kansas City, there are a few practices like this in the KC area that are you actually have paper charts. Is the EMR different for prescriptions versus notes? Is there AI technology emerging for documentation, such as utilization of models where you are recording yourself talking to the patient essentially, and it automatically is coming up with a note that you can then kind of modify and sign? Is there opportunity for discussing difficult cases? Are there any conferences, journal clubs? I am not an expert on the topic of visas, so I am not speaking about this, but if you are an international graduate, just making sure you know all the terms and restrictions associated with your visa. And then consulting for pharmaceuticals, is this something that's allowable within your contract, whether that be a private practice opportunity or a university-based practice? And how does the payment go about for that as well? So these are things that are important for you to know about in your contract: the non-compete, malpractice, compensation, termination rules, capitation payments as well. And who do you discuss that with? Ultimately, it kind of depends, and it's personal based on the individual. You can discuss it with a lawyer. You can discuss it with your program director if your program director feels comfortable with talking you through this. You can discuss this with other faculty. Ultimately, just making sure that there is a discussion open with somebody who has knowledge of language and legal implications of this, because again, this is so important for you to know everything about what you're getting into. Now, importantly, what parts of your contract can and can't be changed? Before you sign anything at all, before you sign any dotted line, please make sure you are knowledgeable about what can and can't be modified. An example here is academic institutions often give you an initial offer letter followed by a contract. The contract is often a boilerplate contract that cannot be modified. However, they may not tell you that an offer letter can be modified to your needs and wants, essentially, or whatever you're asking for. And so that's why I say do not sign anything until you've had somebody that looks over everything and make sure that it's catered exactly towards what you are asking for. And then an important rule, hard life lesson to remember, is if it doesn't exist in the contract, it does not exist. It doesn't matter if something was promised to you over the phone, over an email. If it didn't make it in the contract, it is not something that can be enforced. And so if something is really important to you, if you brought a grant to the institution and you are asking for FTE, or if you are working a certain amount of hours at a private practice and you are asking for that time, the amount of clinics to be written out in your contract, please make sure that it's written in your contract before you sign anything and hand it over, of course. Okay, the hard part, negotiation. So oftentimes when we are new graduates, we are afraid to ask because we may feel, oh, well, they're being generous with what they're offering, and I don't know that I bring anything special to be able to even ask for more. And that is a very real fear that new faculty have. However, we don't know if you can get something or not unless you ask. So my advice is always ask. Ask in a respectful way, but you can ask. And the worst you can be told is no, or hey, we can't work with that, and then you can counter offer something else. But you won't know if you can get something or not unless you ask. So negotiation skills include prioritizing what's important to you. Do you want to do it in writing? Do you want to do it face-to-face? But if you do it face-to-face, make sure you follow up with something in writing. And then Yeah, this can include salary discussion, but it can include any of the things we've talked about. So tailor your requests based on the average of your area that you're applying for. Last couple slides here. What is your referral base? Do you need to build a reputation with the primary care in the area, the other subspecialists, so that you get referrals? Or is it like like I mentioned, a private equity situation where that should be taken care of for you? How many locations do you have to work at? Do you supervise an NP? Do you sign off on their licensure because you're supervising them? What's your schedule like? What's your albuterol and prednisone and epinephrine also? Epinephrine policy as well. I should have just said for individuals. If you're planning on having children, what is the parental leave policy for both parents, both the birthing parent and the non-birthing parent? And do you need disability insurance for your reimbursement for this? Okay, last couple points here. Before you begin, just know what your style is in terms of note templates. Adapt a style, be systematic, be efficient, have contact information for your mentors, network, be comfortable with procedures, what you are willing to do and what you're not willing to do. Request the day off for boards, and specify whether you want that to count as a vacation day or like a day for boards or a CME day or something like that. You can also work with a financial advisor as well to optimize that.